Well, thank you all for attending. My name is Valdez Bravo, president of Healthcare for All Oregon. I use he, him, his pronouns. And we're so excited to invite you, or to welcome you rather, to tonight's webinar where we're going to do a deep dive on Taiwan's healthcare system. This meeting is being recorded for future sharing with those who could not attend. Closed captions are available via this Zoom program. You can find them on the bottom of your screen. And if you need some help with that, I think we'll drop a link here on how to do that. This is the second in a series of informational webinars where Healthcare for All Oregon seeks to really kind of look through through universal healthcare through the lens of an issue or constituency or other topic. Last week, we had our first one where we looked at universal healthcare through the labor movement. Tonight, we're going to be looking at the Taiwanese health system. So for those of you who may be new to our organization, Healthcare for All Oregon, or HCAO, is a 501c3 nonprofit organization who educates about and advocates for an equitable, affordable, comprehensive, high-quality, publicly funded, universal healthcare system that will improve the lives of individuals, families, and communities across Oregon, and we think throughout the United States. If Oregon can be the first, like we've been the first on so many other innovations in healthcare, we believe other states will follow. So for the second webinar, we wanted to take a look at Taiwan's healthcare system, which, unlike the United States, can actually truly be described as a true system. Whereas the United States has a highly fragmented system of groups involving the financing and the insuring and delivering of care and different payers, Taiwan has a much more unified, effective, and fair system, which ensures healthcare is available to all of its people. So we're really excited to have a fantastic panel tonight. Tonight, you're going to be hearing from Dr. I-Ming Parng, Deputy Director General of the Taiwan's National Health Insurance Administration, dialing all the way in 15 hours ahead of us in Taiwan, where it's 10 a.m. right now over there, and tomorrow. Dr. Parng will be lending his direct insights and perspectives as an active leader of the Taiwanese healthcare system. We're going to be hearing from Dr. Chunhuei Chi, a member of Oregon's Universal Health Plan Governance Board, who's a professor at Oregon State University and who was instrumental in the design and implementation of the Taiwanese system 30 years ago, and who's helping build, our plan here in Oregon. And then we're also going to be hearing from Dr. Rebecca Schoon, who's not only a board member at Healthcare for All Oregon, but she's a professor of public health at Pacific University and a former student of Dr. Chi. So all three panelists will help inform an engaging discussion about the Taiwanese model and lessons learned that Oregon can put into practice as we here in Oregon design our own universal healthcare system. But first, we're going to watch a 15-minute video that Dr. Parng and the National Health Insurance Administration shared with me while I was visiting Taipei this past April, which this video does an excellent job providing a comprehensive overview of Taiwan's model. And then after the video, we're going to hear from our speakers. And then don't worry, we're going to get to your questions and we'll hear a 30-minute Q&A. Where you'll be able to ask questions about the Taiwanese health system, what we're doing here in Oregon, or anything in between. So without further ado, I'm going to share my screen. And if I get this right, you'll actually be able to hear the audio. So here we go.
Welcome to the National Health Insurance Administration. This is an overview of Taiwan's National Health Insurance Program, which was launched on March 1, 1995, to provide health insurance for all Taiwan residents. Here's today's agenda. There are over 23 million people living in Taiwan. Over 17% of the population is over the age of 65. As of 2022, GDP per capita reached $32,625 US. Taiwan's national health expenditure was 7.47% of GDP in 2022. Life expectancy was 83.3 years for females and 76.6 years for males. Before our current national health insurance, Taiwan had 13 different social insurance programs, covering specific groups like labor, government employees, and farmers, with provisions like health care and pensions. However, only 59% of the population was covered in 1994. Since its establishment, the National Health Insurance has consolidated the health plans of the aforementioned insurances, providing nationwide health protection to Taiwan citizens and international residents. In order to improve the quality of healthcare, ensure the soundness of finance, and encourage public participation, a second-generation national health insurance was launched on January 1, 2013. Taiwan's healthcare system is mainly dominated by the private sector. Hospitals adopt the closed-staff model, and physicians are primarily salaried by hospitals. There is no gatekeeper system to screen patients. Patients can go to any clinic or directly visit any hospital without a referral. The volume of hospital outpatient services is high as a consequence. However, healthcare is usually provided in a timely way, and waiting time is negligible. Here are the main characteristics of Taiwan's NHI. NHI is a compulsory program, and all residents must enroll. The National Health Insurance Administration is the sole authorized agency to administer the program, including premium collection and medical payment reimbursements. Healthcare coverage is comprehensive, and people must pay a co-payment when seeking healthcare. Though it's voluntary for healthcare providers to participate in this program, about 92% of providers nationwide have contracted with the NHI. Providers are reimbursed through plural payment programs within the global budget payment system. Premium subsidies and co-payment waivers are granted for disadvantaged individuals. Our national health insurance has earned a strong reputation among the people of Taiwan and is widely regarded as one of the nation's most esteemed public programs. The public satisfaction rate has shown significant improvement, increasing from 39% in 1995, the NHI program's inaugural year, to 61% in its second year. It has continued to rise ever since, demonstrating consistent growth, climbing from 81% in 2015 to 91.2% in 2023. The NHI program has not only established a secure healthcare network for all residents in Taiwan, but is also renowned internationally for achieving universal health coverage and providing comprehensive healthcare at an affordable cost. People are ensured easy access to healthcare providers regardless of their ability to pay for care. Public satisfaction remains high, and medical quality is consistently ensured. Our national health insurance is primarily financed by premiums, including general and supplementary premiums. Each person shall remit the general premium according to the premium formula or fixed figures. In addition to the general premium, a supplementary premium has also been collected since 2013. The insured will be charged a supplementary premium of 2.11% on certain incomes received, including large bonuses, professional fees, part-time wages, stock dividends, interest income, and rental income. The insured are classified into 6 categories and subject to different premium calculation bases and contribution shares depending on the category they belong to. Most salaried employees belong to Category 1. They have to pay 30% of their premiums. Their employers pay 60% and the government the remaining 10%. The government subsidizes 100% of the premiums for low-income households and military conscripts. Inmates are also covered under NHI, and their premiums are paid by the government. NHI premiums are calculated on the basis of regular salary income. In the first decade of this century, however, salary income declined as a percentage of national income, leading to premium growth lagging behind income growth and funding shortfalls. The introduction of the supplementary premium on various types of income other than regular payroll has alleviated perennial financial problems. Patients have to present their NHI card when asking for NHI health services. The NHI card contains records of a patient's last 6 visits, drug prescriptions, drug allergies, catastrophic diseases, consent for organ donation, consent to palliative care, and consent to a DNR order. In recent years, cloud technology has been applied, turning the NHI card into a key for additional and powerful functions. In addition, the digital NHI card is extensively utilized in home healthcare, telemedicine, and video consultations. Our national health insurance provides comprehensive benefits that cover inpatient care, outpatient care, drugs, dental services, traditional Chinese medicine, daycare for the mentally ill, and home health care. Expensive health services, such as dialysis and organ transplants, are all covered. The insured must pay co-payments when they use medical services. The co-payment is partially waived in cases where the hospital outpatient visit is arranged through a referral. To ensure that people who really need health care do not lose access because of this cost-sharing mechanism, individuals who meet certain conditions are exempt from making co-payments. If those who are insured require hospital stays, they will be charged to co-insurance, and the rate varies according to the length of their stay. However, this co-insurance was capped at $1,563 per stay for the same disease in 2024, and $2,625 accumulated in 2024, regardless of the disease. The average utilization rate for NHI outpatient services in 2022 was 14.28 visits per person. Those visits include visits for dental care and traditional Chinese medicine. For inpatient care, the average utilization rate was 13.22 admissions per 100 persons in 2022. This number of outpatient visits is substantially higher than that seen in many OECD countries. Since the implementation of national health insurance, the contracted rate of medical institutions has consistently hovered around 92% of all healthcare institutions nationwide. All hospitals are contracted under national health insurance, achieving a 100% contracting rate. Among clinics, dental clinics have the highest contracting rate, reaching up to 98%. Since the inception of NHI, the National Health Insurance Administration has reimbursed healthcare providers based mainly on a fee-for-service payment system. In order to better control health expenditures, the NHIA introduced global budget payment systems, including global budgets for dental care, Chinese medicine, clinics, hospitals, and dialysis. To further rationalize the reimbursement of health services, a Taiwanese version of DRGs was initiated in 2010. To enhance healthcare quality, specific projects have been implemented to address diverse needs. For example, the Integrated Delivery System Plan, initiated in 1999, has improved healthcare in mountainous areas and on offshore islands by dispatching doctors to these areas. This plan is undertaken by metropolitan hospitals, cooperating with local healthcare providers to provide tailored healthcare services according to local healthcare needs. Pay-for-performance and pay-for-value projects for specific diseases have been gradually implemented since 2001, such as for diabetes mellitus, chronic kidney disease, and metabolic syndrome, making healthcare more effective. These patient-centered initiatives ensure better patient access to healthcare. One of the core values of Taiwan's NHI program is to remove financial barriers in healthcare for people through the NHI Fund. This explains why the NHI can cover catastrophic diseases, such as patients with hemophilia, who spend 82 times as much as the average patient. For people who are less fortunate, the government provides several types of assistance to make sure they have access to medical services, such as premium subsidies, financial assistance for the poor, and medical assistance for the disadvantaged. Since 2016, the policy of unlocking NHI cards has removed the fetters imposed on financially disadvantaged people who fear seeking medical care because of overdue premium payments. Originally starting in 2013 under the name PharmaCloud, the NHI MediCloud system has provided health professionals with patients' health data and images to ensure drug safety and enhance healthcare quality. During visits or hospitalizations, health professionals can view patients' records of medications, surgeries, tests, and exams, as well as medical images and drug allergy information through a secure virtual private network. Currently, the system achieves an impressive 90% inquiry rate and 98% usage rate among medical institutions, handling around 36 million inquiries monthly. Since its inception in 2014, My Health Bank has been dedicated to providing individuals with an online health information system accessible via mobile phones and computers. It empowers users to inquire about personal health data, medications, tests, and exams. During the pandemic, it played a pivotal role in managing the distribution of supplies and medical resources, such as face masks, vaccine administration, virus testing, and access to rapid test kits. As a result, user numbers surged from 1.6 million in December 2019 to 11 million by December 2023, nearly 50% of the population. In 2020, Taiwan's NHI initiated reimbursement for telemedicine services, integrating them into the IDS program to enhance healthcare access in remote and mountainous areas, thereby promoting localized healthcare. As of November 2023, 84% of mountainous areas, offshore islands, and remote regions have joined the telemedicine reimbursement program, in addition to 9 acute severe care referral networks. Based on digital infrastructure, telemedicine will be facilitated through digital devices and medical equipment equipped with Internet of Things (IoT) technology to provide smart remote healthcare applications. Currently, teleconsultations are conducted via video between endpoint clinics and telemedicine providers, offering specialized consultations and emergency services. In the future, telemedicine will expand to include residents in long-term care institutions, patients receiving inpatient care at home, individuals in need of home health care, and patients undergoing dialysis at home. This expansion is expected to adopt the patient-to-physician model, adapting to the new normalcy emerging after the COVID-19 pandemic. The NHI digital transformation is currently adapting to the ever-evolving needs of the digital age and enhancing NHI services. By adopting cloud technology and obtaining individuals' consent, the NHIA is able to collect diverse health data, connect with healthcare providers, other government agencies and industries, and offer more extensive services to the public and its partners. To facilitate patient-centered and valued healthcare, the NHIA will employ innovative transformations to enhance the NHI systems, focusing on digital transformation, service optimization, emerging technologies, and innovative models. In pursuit of health for all and sustainability, the NHIA is extending healthcare beyond hospital walls, proactively providing healthcare in communities and homes, and making it more equitable and accessible. To foster holistic care rather than mere healthcare, the NHIA is also encouraging preventive healthcare and facilitating the integration of long-term care. Furthermore, not only is quality healthcare emphasized, a value-oriented payment system is also being established to elevate healthcare. We welcome you to visit our website at www.nhi.gov.tw for updated information. Thank you for watching. We hope you enjoyed today's presentation.
Was that some video or what? So thank you so much to the NHIA for sharing that video with us. Um, just a phenomenal 15-minute capture of so many elements of what is a very complex system. Healthcare is complex, as you all know, but the way they break it down, I hope was as meaningful for you as it was for me. Now, next, we're going to be hearing from Dr. I-Ming Parng, who is the basically the Deputy Director General of the National Health Insurance Administration there in Taiwan. He's in Taipei. It's 10:25 a.m. tomorrow morning there where Dr. Parng is. Hello, Dr. Parng. I'm going to share your screen. I'll share your slides, but the microphone is yours, sir.
Thank you. I think most of you are very appreciate our video. And would you share my slide to all of you? And I'm going to share why we have a so marvelous achievement. So the story and the history very important. So, and it's my topic. And please next. Yeah, next one. Here is the summary. I think you have read this slide in our video, and turn to next, please. Oh, this slide very important, and it is produced by Professor Jiang Dongliang, one of very marvelous professor in National Taiwan University, and he summarized the trend for healthcare reform and the social welfare system. And you can see Taiwan started NHI since 1995, and the next country is Thailand, 2001. So maybe some of United States citizens, as I know, you cannot different. It's very hard for you to differentiate Taiwan and Thailand, and it's quite different. So you can know from national health insurance, we are early than Thailand. Why? Okay, it's a joke. Then turn to the next slide. Before 1995, we also have a very separated program. So this we have a 13 program and 3 major social influence program. That's for your reference. And turn to next slide, please. And the major issue when we design the national health insurance, we should have a NHI and we should have a NHS, and we should have a single authority or multiple entity, and it's the competent authority or not, and how to do enrollment approach, and how much is the coverage is covered. This issue all be debated before 1995. Yes, turn to next. Turn to next, please. And since now we review our successful. I think we have a honesty study and a plan. We have a good negotiation. We have very good strong leadership. We have a very good staff, and we have a very high quality health provider. And after that, we have a very advanced information technology. Now I want to turn to the issue about advanced information technology. Turn to the next, please. This slide is produced by myself. I combine the innovation of IT technology and health policy reform. You can see Taiwan, we start national health insurance since 1995. And at that moment, I cannot sure, you remember at that moment in the cyber world, there was a very powerful software announced Windows 95. Okay. So this stage is very important. And the cyber world trends from mainframe framework to personal workstation framework. So it's the moment Taiwan catch the reform, and also it's a moment Taiwan participated and control the major productivity power in the world to offer good personal computer to the world. So Taiwan's social revolution just combined with the IT revolution. So it's a very excellent moment. Since it's, thank God, we have the very critical chance to do our innovation. So I think you can keep this slide to prove we catch the trend from innovation technology. And turn to next, please. And then since the first day we start national health insurance, we use digital claim since the first day, because at that moment in Taiwan we need national health insurance, and we also let our people to use innovation technology, start from personal computer. So since the first day we start the digital claim for health insurance, and currently we have the achievement just like next. Turn to next, please. So we built a very powerful data warehouse, and we have personal data, we have medical record, we have a physician profile, we have a hospital profile. And 20 years ago, we used the term what we call data warehouse. And come to dentally, it become big data. And the big data let the human have the chance to get the artificial intelligence. So we use our advantage of technology and national health system. We build a very powerful information system. And then please turn to next. And then we have a MediCloud. The MediCloud is just like you see in the video, so I don't take much time to introduce it. We have medical, and turn to next, please. And we also have my health bank. It's just like a personal health record. Turn to next, please. So currently we combine my health bank and artificial intelligence can do many health service just like this we have shown. And turn to next, please. And this is the conclusion I want to share with you, and the lesson you can keep it. Since the healthcare delivery system is fragmented, so all of our problem, most of our problem come from fragmented. And when we introduce IT technology, our innovation technology, the technology is make us to fragment our integration. So since we have the idea, we want to solve the problem of fragmented, we should use the information technology to let us integration and can coordinate it. So sometimes for me, it's very hard to use advanced technology to let us more fragmented. So please keep it. It's my conclusion. Thank you. Thank you very much.
Thank you so much, Dr. Parng. Give it up for Dr. I-Ming Parng, dialing all the way in from Taipei, leading the National Health Insurance Administration. One of the best practice. When I went to grad school 15 years ago, we looked at the best practicing models of who was spending the least amount of money on healthcare and having the best outcomes. Taiwan, right at the top of the list there. So thank you, Dr. Parng, for the work that you're doing there in Taiwan today. You've been doing for years, and then taking time out of your busy schedule to dial all the way in here to Oregon and to share with us. So looking forward to hearing more from you during the Q&A. But next, we're going to move to Dr. Chunhuei Chi. Now, Dr. Chi is a professor at Oregon State University, and he is on the Universal Health Plan Governance Board, which is a 9-member board. Get this, building a universal healthcare plan here in Oregon with public recommendations coming out next September. But Dr. Chi's on that. And the good news is, not his first rodeo. He was involved with the Taiwan model early on. So Dr. Chi, I'd like to pass the microphone to you, my friend. And Dr. Chi, thank you for connecting me with Dr. Parng and NHIA so I could do that visit when I was in Taiwan in April. Thank you.
You're most welcome. Good evening and good morning for those of you in Asia. Thank you for participating in this webinar. And I'm just going to very briefly introduce about my perspective on how Oregon might be able to learn from Taiwan's universal healthcare. And as Valdez mentions, I was invited to involve in the early stage of the planning, and then over the years, I also served different role, either as a full-time visiting researcher or as a consultant. And for 3 years, I was the policy advisors. So I have been extensively involved with Taiwan's universal healthcare. So what I'm going to share with you next will be kind of my bias. Also, even though I'm a member of the Oregon Universal Health Plan Governance Board, but I cannot speak on behalf of the board. I can only speak for myself. And so I just have two summary slides to share. So I'm going to share my slide. Are you able to see my slide?
Yes, Dr. Chi, looking good.
Okay. I just have two slides to show. So first one, again, it's my perspective and also include my bias. So I'm comparing the achievement of Taiwan's universal healthcare versus challenge. So on the left-hand panel, you see the achievement. So it achieved universal coverage and with fairly equitable financial burden. My colleague in Taiwan has done a great job in analyzing the equity of financial burden in Taiwan's universal healthcare, as well as equitable access. And it achieved that at a relative low cost compared with most other OECD countries. Also, it provides easy access. There's no gatekeepers. And some actually criticize, some of my colleagues criticize that both an advantage and a challenge. Also, Dr. Parng, as well as in the video you saw, Taiwan is at the forefront of effective use of information technologies. And the administration is among the most efficient because over the year, they were able to maintain the administrative cost of the system at very low, under 2%. And another advantage that's seldom mentioned is because the universal health system is under the umbrella administration of Ministry of Health and Welfare. So there's a very seamless and smooth integration of healthcare within the population health promotion. And lastly, I think few countries come close when it comes to the public satisfaction of their healthcare system. For the last 5 years, it's persistently above 90%. But this high population satisfaction is a two-edged sword. On the one hand, people are very satisfied, and at the same time, it leads to the first challenge on the right-hand side, underinvestment, because Taiwan spent about 7% of the GDP in healthcare, not just national health insurance, but in all healthcare combined. But in the last few years, many professionals in Taiwan started to argue this is an underinvestment. However, part of the reason there's a high satisfaction is because people pay very small contribution in terms of tax into this system. So it becomes a challenge for administrative, for the government, try to raise the tax. And because of that, the second challenge is there's growing private finance. The out-of-pocket payment in the recent survey indicated above 30% of the total healthcare expenditure. And there's a question, not a concern, but question about whether the equitable access lead to equitable quality. And then number four, the governance has not fully involved the public input. And number five, the weak primary care actually came from one of the advantage, easy access, that there is no gatekeepers. People can just go straight to the teaching hospitals. And therefore, as a result, a sizable percentage of the primary care would taken care of by the tertiary hospital. And that became an issue of a weak primary care. And the contrary to the general public's high satisfaction, there's a relative low provider satisfaction. And that's also a challenge. And then related to the underinvestment, over the last few years, there have been discussion contemplating a possible two-tier system. The second tier will be the supplemental health insurance. More broadly, there are already supplemental health insurance, but there are open discussion about whether to incorporate that into the formal system. So these are my summary of the challenges and achievement. So my second and last slide. Again, I don't speak for the governance board, and this is just my perspective on how some of the Taiwan's policy might be helpful consideration for Oregon. So Taiwan implemented a total global budget since 2002. And Oregon is contemplating global budget in the initial discussion only focus on hospital sectors. But I'm one of the advocates to have the entire budget under global budget following Taiwan's model. And the second policy that we can consider is the reference pricing for prescription drugs. And again, this is under discussion about reference pricing, but also negotiation for prescription drug for Oregon. Number three, Taiwan has a decentralized administration, divided the whole nation into 6 regions. Oregon is also contemplating regional offices to administer once we implement the universal health plan. My personal bias is Taiwan has a relative weak governance related to public input. And in the governance board, we are discussing how we can strengthen governance with active community inputs. Number 5, equitable finance. And this is a very important focus in the governance board. We are discussing how we can implement equitable finance, but also continue to monitor that. Number 6, Taiwan has been effectively integrating healthcare within population health. And we also, number 6, equitable access that we are also considering. In terms of integrating population health, yes, in the governance board, we are trying to learn from Taiwan how we can make the healthcare part of the population health policies. And lastly, effective use of information technology. Oregon is a little bit behind, but once we have the implementation of the universal health plan, we will consider how we can effectively integrate and develop the information technology. And Taiwan is among the leader of the world and has a lot of lessons that Oregon can learn. So that is my quick summary of how Oregon might be able to learn from Taiwan. Thank you very much.
Thank you, Dr. Chi, Dr. Chunhuei Chi, everybody, all the way down there from Corvallis, Oregon. Go Beavers. Thank you, Dr. Chi. All right, before we get to your questions, and I've seen some good ones coming in the chat, we've heard from Dr. Parng, we've heard from Dr. Chi, now we're gonna hear from Dr. Rebecca Schoon, who's a public health professor at Pacific University, Go Boxer, and a Healthcare for All Oregon board member. Go ahead, Dr. Schoon.
Hello, I will keep my comments uncharacteristically short for anyone who knows me. First of all, because we are so fortunate to have Dr. Chi and Dr. Parng here, who are veritable experts in the Taiwanese system. I've been lucky enough to conduct multiple research projects in Taiwan, one of them related to governance, so how to engage lay people, the general public, in health policy making. I was fortunate enough to become familiar with Taiwan system, and I want to say that I knew I had become a true policy nerd when I was researching Taiwan system, and I was overwhelmed with this appreciation for this. There's an elegance to the way it's designed. There's a beauty to it, I feel, that is really impressive. In terms of what we can kind of take to, as Oregon considers a shift to universal healthcare, I think Dr. Chi just went through those in a more detailed manner, but just to zoom out a bit, I think for the Americans on this call here, we often hear a lot of like boogeymen, myths about what universal healthcare systems are like. And one of the ideas I try to impress upon most of my students is that there's such a vast and varied set of universal healthcare systems. There are no two universal healthcare systems that are alike. So oftentimes we'll hear opponents to universal healthcare, for example, say things like, well, we don't want to move to universal healthcare because of the wait times. Look at Canada. So they'll cherry pick a certain universal healthcare system to make a point. Well, we can we can cherry pick the model of Taiwan to reassure a lot of people who might not be familiar with the wide range of universal healthcare systems. As we saw, Taiwan has relatively no wait times, and they enjoy absolute choice. That's another myth that is often communicated when people are trying to drum up fear of universal healthcare systems, that you don't want the government getting in the way of your choices as a patient, limiting your choice of doctors. Of course, there are universal healthcare systems like the UK and Canada that have a strong gatekeeping system, meaning you have to go see a primary care doctor before getting a referral to a specialist. In Taiwan, you can go to any doctor anywhere in the country. And again, they've layered in systems of kind of financial incentives to direct people to local clinics and family doctors first. So it's not it is a free for all, actually. You do have complete choice. But again, they've elegantly, in my opinion, added in systems or policy decisions that help encourage efficient use of healthcare. So there's a lot of examples like that Oregon, the governance board, and Oregonians themselves could become familiar with, to have very positive examples of what we can expect from universal healthcare. Also, I do want to honor our priority of giving half an hour for participants to ask questions. So last thing I'll add is, Taiwan did wait a relatively longer time to implement universal healthcare. When we look at, yes, 1880, when Germany first installed it, or the UK's NHS system that was implemented in the historical wreckage of World War II. But one of the benefits of having waited longer is that Taiwan was able to look at every other universal healthcare system in the world and select the best aspects and combine them in a way that worked for their culture, their political situation. And so Oregon can also mimic that, in that we have the ability to assess different universal healthcare systems, find the elements that work best for us economically, politically, socially. And yes, I would point to Taiwan system as one of the best that we should look to when we consider our choices. With that, I will open it to questions.
All right. Thank you so much, Rebecca. Well, Dr. Schoon, but Rebecca and I serve on the board, so I get to call her Rebecca. Thank you so much for your perspective and sharing that, breaking it down like that. There's so much to respect about the Taiwan model, so much we can learn, and that's why I'm so excited about this conversation tonight. Now we're going to move into questions. And I've been recording some. If you'd like to raise your hand and ask a question, you can do that too, but I'm going to go ahead and jump right in here to questions that I've been seeing in the chat. First off, question, I know this would be for Dr. Parng or for Dr. Chi, but the question is, prior to 1995, were the separate companies providing health insurance, were they for profit organizations before 1995?
Well, Dr. Parng, you're probably the right person to answer this question.
Yeah. And you should be able to unmute Dr. Parng if I've done my part here correctly. Let's see here. Okay, still muted, Dr. Parng.
Well, let me just quickly jump in. Prior to 1995, there was very little private health insurance. What existed at that time was partial government insurance.
Sorry, keep going, Dr. Chi. That was a little bit of an interference.
Yeah. So there were different government insurance for public employee and for public employee that include their family, for private industry employee only for the employee but not family. So, and also for military, for farmers. So those who were uninsured were primarily the family member of private industry employee because the employee were covered but not their family.
Gotcha. Thank you, Dr. Chi. And Dr. Parng, I see you're troubleshooting over there. It's not letting him. I'm sorry. I hit ask to unmute. I don't know.
Can I ask a question?
Miss Lou, I don't know if you're there with him.
One note while they're doing that, I'll add that so while that's a big difference, of course, right? So in Oregon, in the US, we will have considerable opposition from private health insurance, kind of to argue against a shift, which that wasn't the case from private health insurance. But in Taiwan, there was considerable opposition. It was not like everyone held hands and skipped across the line to universal health care. There were labor groups and other groups who were out kind of fighting against it. So almost every shift to universal health care has had to confront that in some way, but just not from private health insurance in the same way.
Thank you, Dr. Schoon. That's important to remember that it was not easy for Taiwan either. Dr. Parng, I see you're unmuted. Go ahead.
Yeah, before I want to share with you, before 1995, our health insurance system of them came from the government. So just like Dr. Chi has said, the military insurance belong to the government, and public employee government also belong to the government. And but we have a very different government authority to handle our system. So it's also a pattern, just like fragmented. So it's not integrated. Even the preview calculation and the benefit for the insured all are quite different at that moment. Yeah.
Okay. Dr. Parng, thank you. While you've got the microphone, I'm going to ask you the next question. How is behavioral or mental health addressed? Is mental health and behavioral health part of the coverage there in the system?
Yeah, I think the mental health system is very powerful in our national health system. Since the first day from 1995, we coverage acute patient care, long-term patient care, middle warehouse care, and even home care since 30 years ago. So compared to other long-term care or other illness or disease, the mental health care system under national health insurance, I think is very, very good. But in our national health insurance law, we have a claim that the national health insurance don't cover the substance or drug abuse. So sometimes if you from the viewpoint of mental health, you should have a good policy or good care for substance abuse. But in Taiwan, the substance abuse is away from the national health insurance. I think it is also it's also a weakness for us.
Oh, interesting. That's interesting. Thank you for pointing that out. Dr. Chi or Dr. Schoon, did you want to add anything to that response?
No.
Okay. Next up question is just in understanding the cost of healthcare in Taiwan, compared to the US? One of our folks asked, seems like the US has an extremely high cost of services compared to other developed countries. Could you speak to the, do you have a lower cost of services there in Taiwan?
I think compared to United States, our cost is very, very low. So just like Professor Chi has said, we got some complaint from our health provider. But if you use another point of view to compare it, you will find our cost came from our struggle and achievement. For example, uh, the the drug use from brand name drug or generic drug compared to United States, our proportion for brand name drug is higher than the United States. But we compared to the single dose price, Taiwan has lower price than United States. That's why Donald Trump want to use the benefit country policy. So it's a very long story. Yeah.
Dr. Chi or Dr. Parng, you told me something funny when I was there. I thought it was interesting when I was visiting, which was that you share your list very transparently with what you negotiate. And so like other countries can
Yeah.
see what Taiwan is paying, but it sounds like because you're negotiating as one system, you're able to get some pretty good drug prices.
Yeah, because the transparency system like us, like our health provider have a good evidence to negotiate the price with the pharmaceutical supplier. So in Taiwan, our national health insurance pays the single price, but our health provider have the power to 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 negotiate with the pharmaceutical provider to get the purchasing price. So there are some price or cost incentive for our cost provider. So sometimes I think it's a benefit for our health provider. But in Taiwan, we also have somebody command the gap of the price is something just like a black hole. So they are quite different point of view. Yeah.
Gotcha. Thank you so much, Dr. Parng. All right, next question I have here is with the National Health Insurance Card, what's the reason why some of the data is only stored for 6 months or a year? Is that due to server capacity issues, or is that privacy issues, or another reason?
Yeah, it's the technology reason because this car is invented since 30 years ago. So I think compared to currently, it's old technology. So 30 years ago, we think the 6 months or the pharmaceutical item is good enough for us. But currently, we know we need more capacity to allow more medical information or medical data. So the 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 content amount of this part is not enough for currently technology. So currently we use this car and the cloud service to provide the information service for our health provider and our people. And as the early stage, we designed this card under a very safety protocol. So if you want to read the medical record from this card, you should have another card. We name it physician card. So you should use the patient card physician card and the institution card, 3 cards in the same time. Sometimes then the physician can read the person's medical record. So the mechanism is very complicated, but I think it's very safe for our patient.
No, thank you so much for that response, Dr. Parng. You know, here in the US, right, with the fragmented system, if you walk into or you go in and you're unconscious, they have no idea what your history is. If they can get the ID, they have to use Epic, break the glass functions to try to see and piece together what's going on with you. And I remember when I was in primary care, that prevention of life-sustaining treatment information, hardly anybody had on record, and it's built right into your card. So the one card, one system thing is truly phenomenal. I'm going to mix it up a little bit here on this question, and Dr. Parng, you can stay unmuted, but I'm going to go to Dr. Chi on this one. Dr. Chi, one of the people said, one of the questions said, when you say universal health care, do you mean health services or a single payer, which means a government insurance that pays the private sector? And then how do you keep the charges under control? So a lot of people, you know, is universal healthcare single payer the same thing, or, you know, what were your thoughts on that one, Dr. Chi?
Yes, universal health care meaning the society, usually the government, using some kind of mechanism, including legal, to assure every citizen and resident of the country have access to health care. So that's the meaning of universal health care. And single payer system is one method of delivering universal health care. And there are countries who choose to use multiple payers, such as the German system, Switzerland system, and Netherlands system. They are still universal health care, but they are not single payer. But if you look at all the OECD country, single payer seems to be a more popular mode. Our neighbor Canada, besides Taiwan, Japan, even though it's subdivided into different administration, but it's still a single payer. And then South Korea, France, and Spain, and many European countries have a single payer. So single payer is one mode of organizing universal health care, but not the only way.
Gotcha. Thank you so much, Dr. Chi. I'm going to bundle a question here, and it's might be for Dr. Parng. 2 parts. It's about training providers. One, how much does it cost for primary care physicians to get medical education in Taiwan? And then also, how does your system incentivize people going into primary care versus specialties? You know, here in the US, everybody goes into specialties because you can make more money and we have a primary care shortage. How do you, how much does it cost to train in primary care in Taiwan? And do you have how do you get folks to sign up to do primary care?
In Taiwan, the primary care the system for to culture primary system or specialist physician, the system is all the same. So in Taiwan, we treat our primary care system just like a family physician. So the system for incubation there, the system is all the same. But they want go to medical center, or they want go to service in district hospital, or they want go to the local clinic. It depends on the personal choice. So the system to educate the different specialists in Taiwan, the system is similar and all the same. And so we have a very good quality primary health physician. We have a very good quality family physician education. But because in Taiwan, our people are happy to visit high-level health providers, so we have the issue about the primary care. But sometimes I will think in Taiwan we have a soft gatekeeper system. We use the different co-payment to different the the stream for our people to visit physician. So we don't use the very hard referral system, just like NHS in UK or the primary care system in United States, just the capitation system. We use the different co-payment amount to differentiate the stream for our people to choose the medical service. But recently, we want to change the situation, just like Professor Chi said. So this afternoon, I have a very important meeting to report to our minister to discuss the new co-payment system. Want to change the status, and we want to let our family physician have a good power to offer our people. And then we also think how to introduce the technology to our primary care. So recently we use cloud technology and information cloud and information technology to let our primary care physician have a good IT tool to service for their patient. So we use both the co-payment policy and the technology support to rebuild our delivery system.
Wow. Okay. Thank you.
I-
That was very helpful.
I'll
Yeah, go
add
ahead.
in one quick thing because it's so distinctive to this system. So primary care and specialists, they have the same fee schedule. So
Yes.
different than the United States. So yeah, when Dr. Parng says it's all the same, most Americans would never consider that that's what he meant. Now, and then there are different, depending on which kind of facility someone goes to. So if they go to a like high specialty, they might pay more. So differences in pay emerge, but not through different reimbursement rates for primary versus specialists. Very different than the US.
And before we go to the next question, Dr. Parng, do you all use nurse practitioners or advanced practice, type providers over in Taiwan? Like, do you have nurse practitioners?
Yeah, since the pandemic, we also should face the problem of a lack of nursing power, and compared to other countries, for example, United States or Singapore, in Taiwan, it's very hard for us to introduce the foreign nurse to our country. But the total amount of our people have the license for nurse is enough in Taiwan. But our problem is they lack of the willing to service in hospital or health provider area, especially in critical care. So we also use the financial incentive and other policy incentive to let them want to stay in critical care or emergency care. So we use many policy to solve the problem.
Gotcha. All right. Thank you, Dr. Parng. We got time for, I've got some questions. I don't know if you all are keep adding questions. I think we have time to get through some more questions here. I'm going to bring this one back to Oregon. So Dr. Chi, Dr. Schoon, this might be good for you too. Somebody said, I'm trying to understand what the fee structure in Oregon would be compared to Taiwan, specifically regarding like individual fees and government subsidies. I know that's a big complex question, but can you provide some information on how the Oregon system could be funded and work? And feel free to plug the governance board committee that's doing that work. Go ahead, Dr. Chi.
Regarding fee schedule, are you talking about the payment system to the provider, or are you talking about the finance, the taxation?
Let's probably finance. Let's do the finance.
Okay. Again, I cannot speak for the governance board, but I can only share what's on the table. We are still considering and not finalized yet. We are far from finalizing it. So right now, under consideration, two major sources. And again, this is not the final. We are still discussing that. One would be income tax, and the other would be payroll tax. But the payroll tax will be levied not at the individual, but at the employer. This is because currently the private employer, the sizable portion of private employer are providing either to the entire cost of health insurance premium or partial cost. And to make it both equitable, but as well as minimize the opposition or resistance, one of the principles we are attempting to do is to help the private employee when we transition into the universal health care relatively financially neutral, meaning one of the plan is those employer contributed health insurance premium will be transitioned into the payroll tax. So the employer may pay payroll tax that's equivalent to what they used to pay for the private insurance for the employee. And those payroll tax will become a tax credit for those employees when they are levied on income tax. And there are additional other revenue sources we are still exploring. And again, this is not final. We are still in deep discussion about how we develop that.
Thank you, Dr. Chi, for those insights. And I encourage everyone to look at the chat. If you want to go to the finance committee, you can see the meeting minutes. You can come to the meeting. It's open to all. Dr. Schoon, did you want to add anything to Dr. Chi? Okay, you're good. Okay. Okay, I'm going to try to get three more questions, and then I do have some closing remarks for you. So hang on. I think we'll be out of here on time. So the one question, this is kind of a big question. And I know Dr. Parng, you had talked to me about this when I was visiting in April, because you have that high satisfaction rate, right? The double-edged sword that Dr. Chi mentioned, where it's like, I love it. Don't change my system, but you might need to change it to keep the cost down. And one of the questions was, with no gatekeeping and such easy access and choice of healthcare, how is hospital shopping or doctor shopping being addressed? Do you have challenges where patients go around to different doctors looking for the right answer, that'll give them the medications or treatment they want?
Yeah, we don't want it, but sometimes the free for choice is a good system in democracy country. So that's what we offer, so marvelous technology support to our health provider. We let our patient can get all their health record, and we let our physician can read the history data of their patient. All of want to do is let our health provider can more integrated and let our patient have the loyalty to their health providers. So actually, if we want to know how much, for example, a cancer patient choose different health providers, so in actually it's very fear for some patients. They are not so loyalty to their health provider. In most of our patients for catastrophic disease or chronic disease or cancer, just like this, they have a very good relationship to their single health provider.
And the nice thing, y'all, is and Dr. Chi, jump in, but they don't have it's not like their employer changes insurance plans and now you lose the doctor that you love and have a relationship with, and now insurance is telling you who you can see, or your network has changed, which is disrupting that continuity of care in that relationship. They don't have that problem, obviously, in this kind of system. Go ahead, Dr. Chi.
Yes, I just want to mention that given the completely free access to any level of healthcare, the role of information technology become very vital. With the implementation of MediCloud, it's very effectively minimize and reduce the duplication of digital imaging, prescription drugs, and diagnostic tests. because the doctor will have real-time access to those information. And also there's a restriction that given the certain diagnosis and within certain time, the doctor cannot prescribe duplicative digital imaging or prescription drug or lab test.
All right. Thank you. All right. I'm going to try to squeeze in 2 more questions and then we'll wrap up. I promise y'all. Quick question, maybe not quick answer, but what does cultural competency look like for training physicians or students who are preparing for medical school in Taiwan? I know that Taiwan has, diversity of different, indigenous communities and, what's culture competency look like there in Taiwan?
I can speak just a little bit because I have an interaction with my colleague in Taiwan's medical school. Taiwan used to be relatively homogeneous in terms of culture until over the last 2 decades. Taiwan started to both import a large number of immigrant workers, mostly from Southeast Asia, and also the mixed marriage, people have a spouse from overseas. And that has stimulated the significance and importance of medical school, not just medical school, but nursing school as well, training how to have the basic cultural competency. Particularly, we have a large number, 2 countries provided the largest source of immigrants workers, Vietnam and Indonesia. And so some of the training particularly tailored to immigrants from Vietnam and Indonesia, but not just limited to these 2 countries, and as well as the English competency also become important for certain providers because not many providers can be trained in Vietnamese or Indonesians, but many of them can speak English. So these are the limited knowledge I learned.
Thank you, Dr. Chi. Dr. Parng.
Yes, in Taiwan, our physicians have a very high social level. So many of our high school students, their first win is go to the medical school. So still now, we in under our national health insurance, we got many complaints from the physician, our physician group. But most of Taiwan's physicians want let their child to study in medical school. So in Taiwan, the physicians have a very higher social status, and even the income for most of them is not so good compared to semiconductor producer. But they have a very good reputation and a very good social status in Taiwan.
Gotcha. Thank you, Dr. Parng. And last question, Dr. Parng. Somebody says that they saw 92% of providers participate in the national health insurance plan. Are the ones who are not in the plan like concierge clinics or something else? And are they allowed to provide services like duplicate services that the NHIA would otherwise provide? And that was great. And like, if they're not in there, like, are they dissatisfied because of pay? Like, why are they not in the plan?
No, some of them service for cosmetics. Some of them service for very traditional Chinese medicine or some dentist. So most of our physicians, they have contract with national health insurance, and all hospitals in Taiwan have a contract with national health insurance. So we actually have the crisis that some young physicians don't want to participate the national health insurance. But the reason for them, sometimes they prefer to have the job, don't have so much duty. So it's also another problem for us.
Thank you so much. All right, that's it for our questions, everybody. Thank you so much to our amazing panelists from Taipei to Corvallis to Portland. I think Dr. Schoon's in Portland right now. Maybe not. I don't know. She's a jet setter. Thank you all. This was an awesome panel. I've been looking forward to doing this ever since I got back from Taiwan in April. So I'm so thankful that all of you could join us for this conversation tonight. We will post, or actually we have posted that Taiwanese healthcare system video on our HCAO YouTube. So feel free to check that out and share it around in your circles. I do have a few final remarks, which is it wouldn't be a great meeting for HCAO without a call to action. So here's just a few actions in the spirit of empowering to get involved in the movement. So please do, if you haven't already, go to www.hcao.org and join the movement if you have not already. Simply just adding your name to a statement of support helps us by adding your name to our list of supporters and shows our strength and the popularity of this grassroots movement. We've added 7,000 names in the past year. We've got 45,000. We want to keep that growing. Also, you can become a member for as little as $5 a month or $30 a year if you'd like to support the work as a member. We're 90% funded by individuals like yourselves, and every dollar goes towards organizing our advocacy efforts. Also, and I think someone will drop the link there for HCAO. Also, we mentioned the Universal Health Plan Governance Board. Dr. Chi is on, he's one of 9 members on that Universal Health Plan Governance Board. They meet regularly. The big board meets monthly. The subcommittees of communications and marketing, plan design, operations, and the finance committee, they meet monthly as well. They're working together to create the plan, and those recommendations are due out next September. But now is the time to make your voice heard and to call on them to design a plan that's simplified, fair, and equitable. So please visit our Universal Health Plan Governance Board website. There's only one in the US. Just Google it, and you can find out all about when those committee meetings are. And then last but not least, get involved with Healthcare for All Oregon. Whether you're interested in volunteering, in organizing events, or serving on the board, Healthcare for All Oregon welcomes everything in between. So you can visit our volunteer page on our HCAO website to volunteer, or you can email us at volunteer@hcao.org. Also, feel free to email me directly at president@hcao.org if you really want to be on that board. But there's links to volunteer, and we have events all over the state, not just in Portland. If you like this webinar, we've got one next week on Wednesday night, November 12th, which is going to be with Dan Shea, Veterans for Peace, Betsy Zucker, a former VA provider, Suzanne Gordon, who's written those books about advocating for how the VA has the best model and fighting privatization of the VA, and myself, an Army veteran as well. Dan and I are both Army, being on a veterans panel about universal healthcare through the lens of veterans. Not all veterans can or choose to receive care from the VA, so you can join in next Wednesday night at 6 p.m., just like tonight, and hear about how universal healthcare would reinforce, not replace, the high quality care provided by the VA. So thank you all so much for attending. We'll try to make this recording available to those who had to drop early or missed it. And just thank you again for your support and interest in universal healthcare. And thank you again to our friends from the National Health Insurance Administration in Taiwan, to Dr. Parng, to Dr. Chi, who helped get it up and running, who's bringing those lessons learned back to build our plan, and to Dr. Schoon, who advocates every day for universal healthcare here in Oregon. Thank you all so much. Have a great night, and hope to see you on next week's veteran webinar. Appreciate it.
Thank you very much.
Thank you. Thank you very much.
Thank you. Thank you, Dr. Parng.
Thank you.